Hello and welcome back to chapter 14. This is part 2. We're going to go over the secondary assessment of the trauma patient. So injuries can range from slight to severe, and we're going to determine how serious an injury is by considering the location of the injury or injuries on the patient and their mental status. We're also going to consider the patient's airway status, the vital signs, the mechanism of injury, and the patient's age or pre-existing conditions. So trauma patients with minor injury or low priority, the assessment is focused on areas the patient notes are painful or that mechanism of injury indicates. Determine the chief complaint, conduct a history of present illness to gain information on how that injury has occurred. So we're going to determine the chief complaint. This is basically what the patient tells you is the matter. We're going to conduct a history of the present illness, what kind of nature forces were involved, direction and strength of the force, protective equipment used by the patient, actions taken to prevent or minimize injury, and areas of pain and injuries resulting from incident. So the physical exam, these are areas assessed, depends on the injuries and the chief complaint. The mechanism of injury may point to potential injuries. Again, when we talked about like seeing size up and we were looking at rollovers and various other things, just the fact that, it was a rear end accident could indicate, whiplash or some type of spinal injury. So 3 techniques: observation, palpation, and auscultation. Again, you can't do a proper exam, you can't do a proper assessment on your patient unless you put hands on your patient. You have to put hands on your patient. Okay, so we're going to perform a physical exam of the relevant body systems. For the physical exam, you're going to examine all relevant body systems: the respiratory, cardiovascular, neurologic, endocrine, GI, reproductive, and genitourinary. So observe for abnormalities in symmetry, color, shape, movement. All of these things can indicate some sort of injury. Palpate for abnormalities in shape, temperature, texture, and sensation. Auscultate for decreased or absent breath sounds. Either of these things can be like, if you've got both of them or one of them, you could have a pneumothorax or something like that. So DCAP BTLS, this is the mnemonic that we use to really kind of help us remember what we're looking for in each body section. So DCAP BTLS stands for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. So we're looking for all of these things when we do our physical exam. Okay, so then we're going to obtain baseline vitals and a past medical history. After the physical exam is conducted on a trauma patient, then assess his baseline vitals and take a past medical history. Use sample and other pertinent questions when examining the patient. Sample, again, is signs and symptoms, allergies, medications, pertinent past history, and last oral intake, and what happened leading up to the injury or illness. Applying a C-collar. So apply a C-collar if they have a mechanism of injury for it, they have a history, or signs and symptoms indicate. So vehicle accidents and various other things, falls, significant falls would indicate a mechanism of injury. You're seeing now that we are getting out of the habit of backboarding patients, but that doesn't mean that they don't have necessarily a cervical fracture or something like that that needs to be dealt with. So there's a process that you have to go through in order to really determine whether they need a C-collar or if they can just be on the cot, on the cot without anything. We don't transport any longer on the backboard, so we're really just getting right there and putting a C-collar on if necessary. Okay, so we're going to measure the patient's neck, measure the collar. The chin piece should not lift the patient's chin and hyperextend the neck. Make sure that the collar is not too small or too tight, which can cause the collar to act as a constricting band. So assess the patient's neck prior to placing the collar, reassure the patient, size the collar, remove any jewelry and move hair. Keep the patient's head in that inline anatomical position and slide the collar into place from front. Okay. So applying a C-collar, a collar alone does not provide adequate inline stabilization. So this is kind of a bad slide because we don't place patients on a backboard any longer for real world situations. However, the book, National Registry, they're all saying that you still place patients on a backboard. There are still some services who are still doing that, but you're getting harder to find those type of services. So trauma patient with serious injury or multi-system trauma or high priority. So we're going to continue spinal stabilization and consider ALS personnel. Okay. So the secondary assessment for a trauma patient with significant injury, we're going to do a rapid trauma assessment. So basically what we're going to do is we're going to assess each part of the body for that DCAP BTLS. You have to palpate, you have to feel, you have to put hands on the patient in order to check for these things. Okay. So it requires only a few moments and should be performed on scene. Care for those injuries that you found can be provided en route, and it will be based on this assessment. So rapid assessment of the head, we're going to palpate the cranium, face, ears, eyes, nose, and mouth. We're going to check for blood or clear fluid in or around the nose or the ears. These indicate probably a head injury of some type. Rapid assessment of the neck. We're going to check for any wounds, tenderness, deformities, and jugular vein distension. And we're also going to check to see if they have a stoma or a tracheostomy. Again, when we check each one of these things, we're looking for that DCAP BTLS. Okay, so chest and abdomen is the same thing. We're going to add in auscultating for breath sounds. We're looking for presence, absence, and equality in those. Again, check for wounds, tenderness, deformities, plus crepitation, and paradoxical movement. That paradoxical movement is where one side of the chest moves and the other, and the portions around it don't move when they either inhale or exhale. We're going to apply a C-collar, check the chest. Okay, your patient has to be naked in order for us to be able to effectively do an assessment on them. Okay, in our abdomen, we're going to check for distension, any pulsating masses, We're going to check the pelvis for bleeding and priapism. Priapism is when you have basically you have an erection that doesn't go down. Priapism is a sign of a spinal injury of some kind. And then we're going to check the extremities. We're going to check for that decap BTLS, and we're going to add in PMS, okay, pulse, sensation, and motor function. So we're going to check for that too. Okay, so posterior body and putting them on a backboard. So we're going to roll the patient on their side and then assess their back. So what we're checking when we check the back, we're checking for that decap BTLS. We're also checking for any kind of step off where the spine is flat normally, and then but what happens with step off is you either get the spine will start flat and then come out and then go back down to a flat position, or it will go in to the body. And then we're going to obtain our baseline vitals and past medical history. Okay. So some general principles: communicate with the patient, expose the injured area before examining it, maintain eye contact, assume spinal injury, and stop or alter the assessment process to provide care. So assessing distal circulation in the upper extremities by feeling for radial pulses, checking for the patient's ability to move both hands. Okay. Assess strength in the hands by asking the patient to squeeze your fingers. Feeling the posterior tibial pulse just behind the medial malleolus, which is the knob on your ankle. Okay. So on a pediatric note, lesser mechanisms can cause significant damage to pediatric patients, and explain your assessments more thoroughly when you're dealing with the pediatric patient. So what criteria would you use to decide whether to perform a focused physical exam or a rapid trauma exam? So what criteria goes into that? So a focused physical exam is more for the type of patient that they don't necessarily need that big, huge trauma level 1 trauma center, but they do need care. Okay, they've been in some kind of accident. They've had some kind of injury. A rapid trauma exam would be for those patients who are critical. They're unresponsive. They have major bleeding, bleeding that can't be controlled. They have a head injury. They have absent breath sounds or something like that. So in the detailed physical exam, typically this is completed en route to the hospital. We're going to gather additional information, and it complements the primary and secondary assessments. This is performed after all critical interventions are completed, and the primary assessment is reevaluated before initiating this detailed physical exam. Okay, so a trauma patient with significant injury, for these patients you will have assessed almost the entire body during the rapid trauma assessment. Now you need to assess the entire body more thoroughly to possibly reveal signs or symptoms of injury you may have missed, or may have changed since the rapid trauma assessment. So before beginning the detailed exam, remember to perform this only after you've performed all critical interventions. Again, you can't do anything else unless if you don't have an airway, breathing, or circulation. If you don't have any of those, you've got to fix those first before you can do anything else. So if you're treating a severely injured patient and are too busy to complete the detailed exam, it is not a failure. Okay. It's your responsibility to give the patient the best care possible, which may mean skipping the exam in order to maintain your ABCs. Okay, so we're going to expose the patient. work around any kind of equipment, and it has components similar to the rapid trauma exam, except it's a little bit more detailed and focused. Okay, so for a trauma patient who is not seriously injured, generally this does not need a detailed physical exam, but you want to keep a high index of suspicion. When in doubt, perform that detailed exam. Be aware of the patient's fear and need for emotional support. So sorry, we're going to skip that question. So mid-chapter review. The patient without a significant mechanism of injury receives a history of the present illness and physical exam focused on areas that the patient complains about and areas that you think may be injured based on the mechanism of injury. Gather a set of vitals and a past medical history. So for the patient who has a significant injury or a mechanism of injury, ensure that you continue your manual stabilization, consider advanced life support, get a brief history and present illness, and perform a rapid trauma exam. So in the rapid trauma assessment, look for wounds, tenderness, deformities, that DCAP BTLS, okay, plus certain additional signs as appropriate while you're doing that part of the body. Systematically examine the head, neck, chest, abdomen, pelvis, extremities, and posterior body. Let me say something that if you don't do it systematically, you're going to miss something. So you need to do it the same way every single time, and it needs to be exact, okay? So after assessing the neck, apply the C-collar, and then after completing the physical assessment, immobilize the patient onto a backboard and get a baseline set of vitals and a past medical history. So after you have performed after you have performed the appropriate critical interventions and begun transport, the patient may receive a detailed physical exam en route to the hospital. The detailed physical exam is very similar to the rapid trauma assessment, but there is time to be more thorough in this assessment, and the detailed physical exam does not take place before transport unless transport is delayed. Okay, the detailed physical exam is most appropriate for the trauma patient who is unresponsive or who has significant injury or unknown mechanism of injury. A responsive trauma patient with no significant injury or mechanism of injury will seldom require a detailed physical exam. Okay, so just remember for the trauma patient that we're trying to go do it as quickly as possible, while not necessarily wanting to miss anything. So it has to be detailed. It has to be thorough. Okay. All right. So this was part 2. It was the secondary assessment of a trauma patient. So part 3 will be coming up. If you have any questions, leave them down in the discussion post below, or email me, call me, text me, whatever is easiest, and I will answer those questions.